A woman goes into labor at 3 a.m. in a mountain village where the temperature outside has dropped to minus 58 degrees Celsius. There is no hospital within 3 days' travel. No doctor. No medical equipment. No heated delivery room. No emergency backup if complications develop. No pain medication. No sterile surgical tools. No way to call for help if something goes wrong. The nearest midwife is the woman's mother-in-law, whose medical training consists entirely of attending births in this same village for 40 years. The delivery room is an underground chamber lit by oil lamps, with stone walls and an earth roof. The only heat source is a small fire that must be carefully managed, because too much smoke will suffocate everyone in the sealed space, and too little fire will allow temperatures to drop to levels where a newborn infant will die within minutes of birth. In the next room, this woman's 3 other children are sleeping. The oldest is 6 years old. If this birth goes wrong, if the mother dies or becomes too ill to care for them, those children face winter in a village where resources are already stretched to the absolute limit, and where taking in orphans could mean the difference between a family surviving winter or not surviving it. The contractions are intensifying. The baby is coming whether conditions are ready or not. And in the next few hours, this woman will either successfully bring a new life into the world under conditions that would terrify modern medical professionals, or she will become another statistic in a place where maternal and infant mortality rates are among the highest on Earth. This isn't a story from centuries ago. This is happening right now, today, in villages in the Afghan mountains where winter temperatures regularly drop below minus 60 degrees Celsius, and where pregnancy and childbirth occur without any of the medical infrastructure that modern people take for granted as basic necessities. Before we reveal exactly how women in the coldest Afghan villages manage pregnancy and survive childbirth in these extreme conditions, drop a comment with where you're watching from. And if stories of human resilience under impossible circumstances fascinate you, hit that subscribe button, because what you're about to learn will change forever how you think about childbirth, survival, and what the human body can endure. To understand how pregnancy and birth work in these conditions, you first need to understand what minus 63 degrees Celsius actually means for a pregnant woman and a newborn infant. Because the cold isn't just uncomfortable. It's a constant threat that affects every aspect of pregnancy from conception through the critical first weeks after birth. A pregnant woman's body is already working harder than normal. Pregnancy increases metabolic rate by 15 to 20%, meaning the body is burning more calories and generating more heat just to maintain the pregnancy. In a normal environment, this increased heat generation is manageable. In an environment where temperatures regularly drop to minus 50 degrees Celsius or lower, this increased metabolic demand occurs while the body is simultaneously fighting to prevent heat loss to an environment that is trying to freeze everything it touches. The extra weight of pregnancy, which averages 11 to 16 kilograms by late term, changes how a woman moves and how much energy she expends doing basic tasks. In a mountain village where survival requires continuous physical work, gathering fuel, hauling water, preparing food, caring for livestock, maintaining the home, pregnancy doesn't excuse anyone from these duties. The work continues, the energy expenditure increases, and the caloric requirements rise at a time when food is often scarce. The village where a laboring mother lives sits at 3,900 meters above sea level. At this altitude, every breath contains roughly 40% less oxygen than at sea level. A pregnant woman's body needs more oxygen to support the developing fetus, but the environment is providing less oxygen per breath. The body compensates by breathing faster and working the cardiovascular system harder, but this compensation itself requires energy and creates additional strain. The combination of cold, altitude, physical demands, and pregnancy creates a survival challenge that would overwhelm most modern women who haven't spent their entire lives adapting to these conditions. Women in these villages don't just endure pregnancy under these conditions. They continue functioning, working, contributing to household survival, while their bodies are managing the enormous task of growing another human being. The pregnancy itself requires adaptations that women in heated, sea-level environments never face. The clothing system that keeps non-pregnant women warm has to be modified continuously as the pregnancy progresses and the woman's body changes shape. The layered wool and sheepskin garments that are essential for survival have to accommodate an expanding abdomen while still providing adequate insulation and wind protection. The sleeping arrangements that keep families warm through winter nights have to be adjusted as pregnancy advances. A heavily pregnant woman positioned at the edge of the sleeping cluster, where she would normally sleep, faces more cold exposure than her body can handle while managing pregnancy. She moves toward the center positions, displacing children or healthy adults who can better tolerate the colder edge positions. The nutrition required to sustain pregnancy in these conditions is higher than in moderate climates, but food availability is often lowest during the winter months when pregnancy might be in its final stages. The traditional diet of preserved meats, dried dairy products, stored grains, and limited fresh foods has to provide all the nutrients a developing fetus requires. Deficiencies that would be minor in well-nourished populations become serious when the baseline nutrition is already marginal. Iron deficiency is particularly dangerous. Pregnancy requires increased iron for the expanded blood volume the mother's body creates and for the fetus's development. The high-altitude environment already stresses red blood cell production. Combined pregnancy, iron demands with altitude adaptation requirements, and limited dietary iron sources, and anemia becomes a serious risk that increases the danger of hemorrhage during delivery. The prenatal care that modern pregnancies receive, regular checkups, ultrasounds, blood tests, monitoring of fetal development, early detection of complications, doesn't exist in these villages. A woman knows she's pregnant when she misses her period and experiences pregnancy symptoms. She monitors the pregnancy's progress by how she feels and by consulting with older women who have experience with pregnancy signs and symptoms. Complications that modern medicine would detect early and manage proactively often aren't identified until they become acute problems. A pregnancy developing problems might not be recognized until labor begins, and those problems manifest in ways that threaten both mother and baby. The margin for error is zero, and the price of complications is often death. As the pregnancy advances toward term, preparations for birth begin. These preparations are as much about thermal management and survival infrastructure as they are about the birth itself, because delivering a baby in -60 °C conditions requires solving problems that modern hospital births never face. The birth space must be warm enough that a newborn emerging from a 37°C womb into the outside air doesn't immediately develop life-threatening hypothermia. This requires preparing a space that can be heated to levels higher than normal living spaces are maintained, using fuel that is already scarce and must be carefully rationed through the winter. The underground chamber where birth will occur is prepared weeks in advance. Additional insulation is added to the walls and ceiling. The entry passage is sealed more completely than usual to prevent any cold air infiltration. The floor is covered with extra layers of felt and wool to ensure that no cold radiates upward from below. Heated stones are prepared and tested to ensure they can be maintained at appropriate temperatures throughout the labor and immediate postpartum period. The fire system is checked and optimized. The ventilation must be adequate to prevent carbon monoxide accumulation while minimizing heat loss. The smoke hole must draft properly. The fuel supply must be positioned for easy access during labor, when no one will have time to leave the birth chamber to retrieve more fuel from outside storage. Water must be available, heated water for cleaning, cool water for drinking. In an environment where water is frozen solid outside, this means bringing in snow or ice days before the expected delivery and melting it slowly so that adequate water reserves are available when labor begins. Clean cloths are prepared, soft worn fabrics that have been washed and dried for wrapping the newborn and for managing the blood and fluids of delivery. In an environment where washing and drying fabric during winter is nearly impossible, these cloths are prepared during warmer months and stored specifically for this purpose. The birth attendants are identified and prepared. The woman's mother or mother-in-law typically serves as the primary midwife if she's available and experienced. Other women who have given birth successfully are recruited to assist. These attendants prepare themselves by ensuring they have the knowledge, the materials, and the mental readiness to manage whatever complications might arise. The knowledge these attendants possess isn't from medical textbooks. It's empirical knowledge developed through generations of births in these exact conditions. They know what normal labor progression looks like and what signs indicate problems. They know how to position a laboring woman to facilitate delivery. They know how to manage common complications using only the materials and techniques available in the village. They also know when a situation is beyond their ability to manage, though in this environment, that knowledge is often academic because there's nothing that can be done. A complication that requires surgical intervention or blood transfusion or emergency medical care simply cannot be addressed. The attendants do what they can with what they have, and sometimes that's enough, and sometimes it isn't. When labor actually begins, the woman moves into the prepared birth chamber, and the real test of the preparation begins. The fire is built up to maximum safe level to load thermal mass for the hours ahead. The attendants gather. The family reorganizes to continue functioning while the birth occupies the attention and space of multiple crucial household members. Labor in these conditions is fundamentally the same biological process as labor anywhere, but the environmental context makes everything harder and more dangerous. The woman must manage the pain and physical demands of contractions while maintaining core body temperature in a room that, even with the fire burning, might be only 12 to 15 degrees Celsius. She must stay adequately hydrated in an environment where the air is extremely dry and where dehydration happens faster than in humid environments. The labor progresses through stages that the attending women monitor with attention born from experience where missing warning signs meant dead mothers or dead babies. The contractions intensify, and the woman moves through positions that facilitate delivery, squatting, kneeling, supported from behind by attendants who bear some of her weight, while gravity assists the baby's descent. The positioning is deliberate and based on generations of observation about what works. Lying flat on her back, the position that became standard in Western hospital birth for the convenience of physicians, is never used. It works against gravity, makes pushing less effective, and increases the risk of complications. The woman remains upright or semi-upright throughout labor, using positions that her body and the baby's progress dictate. The room temperature is managed obsessively. Too cold, and the laboring woman expends energy fighting hypothermia that she needs for the work of delivery. Too warm, and the smoke from the fire necessary to maintain that temperature creates breathing difficulties. The attendants adjust the fire continuously, adding fuel when temperature drops too low, damping it when smoke accumulates too heavily. As the baby crowns and the final stage of delivery approaches, one attendant positions herself to receive the infant. Her hands have been washed in the warmest water available and dried. She's prepared for the moment when the baby emerges wet and vulnerable, when every second of exposure to air that's 50+ degrees colder than the womb could push the infant toward hypothermia. The baby emerges in a rush of fluid and is immediately caught by the waiting attendant. Before the umbilical cord is cut, before anything else happens, the baby is placed directly against the mother's bare chest, skin to skin. This immediate contact serves multiple critical purposes that the attendants understand from experience, even without knowing the modern medical terminology. The mother's body, still heated from the exertion of labor, provides the warmest possible surface for the newborn. The direct skin contact allows maximum heat transfer from mother to baby with no fabric barrier, reducing efficiency. The baby's cold, wet skin against the mother's warm body begins warming immediately through conduction. While the baby is positioned on the mother's chest, the attendants quickly dry the infant's skin with soft cloths. Wet skin loses heat through evaporation dramatically faster than dry skin. Every bit of amniotic fluid left on the baby's surface is pulling heat away as it evaporates. The drying is thorough and rapid, working from head down to ensure the baby's head, the largest surface area relative to its mass, doesn't continue losing heat unnecessarily. As the baby is dried, thick layers of wool are placed over both mother and infant, covering them completely and trapping the warmth of the mother's body around the baby. The baby is never removed from skin contact with the mother during this critical initial period. All care, drying, covering, initial assessment, happens while the infant remains pressed against the mother's chest. The umbilical cord is left attached until it stops pulsating, which typically takes several minutes. This delayed cord clamping, now recognized by modern medicine as beneficial for allowing complete blood transfer from placenta to baby, is standard practice born from observation that babies who receive this extra blood did better in the challenging first days. When the cord is cut, it's done with a blade that has been heated in the fire moments before, which both sterilizes the metal and cauterizes the cut end, reducing bleeding. The cord is tied with thread that has been boiled in preparation for this moment. The stump is left exposed initially to dry, then later may be treated with ash from the fire, which has mild antibacterial properties. The placenta must be delivered, typically within 30 to 60 minutes of the baby's birth. The attendants watch for signs of placental separation and guide its delivery with gentle traction on the cord. This is a dangerous moment. If the placenta doesn't deliver completely, if fragments remain inside the uterus, the woman faces hemorrhage and infection that will almost certainly kill her without medical intervention that isn't available. The delivered placenta is inspected carefully. Experienced attendants know what a complete placenta looks like and can recognize if pieces are missing. If incompleteness is suspected, manual examination or even manual removal of retained fragments is attempted despite the pain and danger, because leaving them guarantees a worse outcome. Hemorrhage after delivery is the most immediate threat to the mother's life. Some blood loss is normal and expected, but excessive bleeding can kill a woman within minutes. The attendants monitor blood loss closely, and if hemorrhage begins, they respond with the limited interventions available. The primary intervention is uterine massage, firm pressure applied to the woman's abdomen to stimulate the uterus to contract. A contracted uterus clamps down on the blood vessels that supply the placenta, stopping the bleeding mechanically. This massage is painful but essential, and it's applied aggressively when hemorrhage threatens. The baby is encouraged to nurse immediately if the mother's condition allows. Nipple stimulation from nursing triggers the release of hormones that cause uterine contractions, providing natural reinforcement to the manual massage. A vigorously nursing newborn is actually helping to save the mother's life through this hormonal mechanism. If bleeding continues despite these measures, the attendants have few additional options. Herbal preparations that have been observed to help with bleeding might be administered. Teas made from plants known to have astringent properties. Cold compresses applied to the abdomen might help. But ultimately, severe hemorrhage in this environment is often fatal, and everyone present knows it. The hours immediately after delivery are almost as dangerous as the delivery itself. The newborn must establish breathing, must maintain body temperature, must begin feeding. The mother must recover from the physical trauma of delivery, must manage pain without medication, must begin producing milk adequate to sustain the infant. The baby never leaves skin-to-skin contact with the mother during these first hours. The thermal protection this provides is irreplaceable. Even with the room heated to maximum safe temperature, the air is still dangerously cold for a newborn whose thermoregulation is immature. The mother's body provides a stable heat source that keeps the infant's temperature in a safe range. After several hours, when the baby has stabilized somewhat, minimal clothing is added. A soft wool cap that covers the entire head and ears is essential because the head represents disproportionate surface area through which heat is lost. Soft wool wrappings for the body follow, creating insulation layers while still maintaining some skin contact with the mother. The baby remains in constant contact with the mother for days after birth. This continuous contact serves thermal regulation, facilitates continuous nursing, and provides the security and comfort that the infant needs. In an environment where placing the baby in a separate cradle would expose it to temperatures that could be fatal, the practice of continuous mother-infant contact is an optional affection. It's survival necessity. Nursing must be established quickly because the infant has no reserves to sustain it through delays. The first milk, colostrum, provides critical immune factors and concentrated nutrition. The baby's instinct to nurse and the mother's instinct to feed must overcome the challenges of learning how to achieve effective latch and milk transfer. The attendants assist with positioning, with recognizing successful feeding versus ineffective attempts, with identifying problems like tongue tie or poor latch that prevent adequate milk intake. A baby who isn't feeding effectively will weaken rapidly, and a weak baby nurses even less effectively, creating a downward spiral that can be fatal within days. The mother's nutrition during the postpartum period is prioritized by the entire household. She receives the best available food, the fattiest meat, the richest dairy, the most nutrient-dense preserved foods from the winter stores. This isn't generosity, but calculated investment. A well-nourished mother produces abundant milk. Abundant milk means a thriving infant. A thriving infant means the family has successfully added a member who will eventually contribute rather than losing the mother's labor during pregnancy and delivery with nothing to show for it. The cultural practices around postpartum care reflect accumulated knowledge about what supports recovery and what threatens it. The mother is expected to rest as much as possible for at least the first week, ideally 2 weeks, with other women taking over her normal household responsibilities. This forced rest allows her body to heal from delivery trauma and to establish milk production without the competing demands of physical labor. The mother stays in a warm birth chamber for days rather than immediately returning to the normal colder living spaces. This protects both mother and infant from cold exposure during the most vulnerable period. The extra fuel consumed to maintain this warm space is considered essential rather than optional, even when fuel supplies are critically low. The infant's first weeks are a battle to maintain adequate temperature, to establish feeding, and to avoid the infections that can kill a newborn whose immune system is still developing. The constant skin contact, the continuous nursing, the obsessive protection from cold, all of these practices that might seem excessive are actually barely adequate for the conditions. Infant mortality in these villages is high. Exact statistics are unreliable because births and deaths aren't always officially recorded, but estimates suggest that 15 to 25% of infants don't survive their first year, with most deaths occurring in the first month. Many of these deaths are directly or indirectly attributable to cold exposure, inadequate nutrition, or infections that thrive in conditions where hygiene is compromised by the impossibility of regular washing in winter. Maternal mortality is also elevated compared to populations with access to modern medical care. Estimates suggest 1 to 3% of births result in maternal death from hemorrhage, infection, or complications during delivery. In a village of 200 people, where perhaps 5 to 8 births occur per year, this means a maternal death every 3 to 5 years on average, frequent enough that everyone in the village has lost someone they knew. These statistics would be considered catastrophic in modern medical contexts, but they represent successful adaptation to conditions that should make human reproduction nearly impossible. The fact that births occur and that most mothers and babies survive is a testament to the knowledge system that these communities have developed and maintained. That knowledge system is transmitted entirely through direct experience and observation. Girls grow up attending births from early childhood, observing the process, learning what normal looks like and what signs indicate problems. By the time a woman has her first baby, she's already witnessed 10 to 20 deliveries. She knows what to expect, knows what pain is normal, knows what signs would trigger calling for the experienced attendants. The attendants themselves accumulate knowledge across decades of births. A woman who has attended 100 deliveries has seen every common complication and many rare ones. She knows what interventions have worked in the past and what attempts have failed. This knowledge isn't written down, but is encoded in practice and transmitted through demonstration and supervised participation. When a difficult birth occurs, when complications arise that challenge even experienced attendants, the entire community's accumulated knowledge is brought to bear. Older women who haven't actively attended births in years may be consulted for their memories of similar situations. Solutions that worked generations ago are retrieved from community memory and attempted again. The system isn't perfect. Women and babies die despite everyone's best efforts. But the system works well enough that the population sustains itself, that births continue, that the community persists through conditions that would kill unprepared populations within a generation. The woman who went into labor at 3 a.m. in minus 58 degrees Celsius temperatures delivers her baby after 14 hours of labor. The delivery is straightforward with no major complications. The baby, a girl, cries immediately upon birth and nurses vigorously within the first hour. The mother loses blood within the expected range, and her uterus contracts effectively after the placenta delivers completely. 3 days later, both mother and baby are doing well. The baby has regained her birth weight, indicating successful milk transfer. The mother's postpartum recovery is progressing normally. The extra fuel consumed to keep the birth chamber warm through these critical days has depleted the family's winter supply, but the calculation was made that the birth justified the expenditure. In 6 weeks, the mother will return to her normal work responsibilities with the baby wrapped against her body in wool and sheepskin, kept warm by her body heat while she performs the tasks that winter survival requires. In 6 months, the baby will have survived the most dangerous period and will have odds approaching those of the adults for making it through to spring. The birth happened without hospitals, without doctors, without medical technology, without pain medication, without any of the infrastructure that modern people consider essential for safe childbirth. It happened because women in this village possess knowledge refined through generations of births under these exact conditions. Knowledge about what works and what kills. Knowledge transmitted from grandmother to mother to daughter in an unbroken chain extending back centuries. That knowledge isn't romantic or mystical. It's brutally practical information about heat management, about birth mechanics, about infant care, about what the human body can endure and what it cannot. It's knowledge that keeps families alive in conditions that should make human reproduction impossible. Knowledge that represents humanity's remarkable ability to adapt to environments at the very edge of what our species can survive.